Critical appraisal. I expect many supervisors are thinking, how relevant is that to my role? Like me, many of you trained during a time when there was no such thing as evidence-based medicine. We listened carefully to what experts had to say, and even if it was at times contradictory, it was still good enough. GPs didn't read research articles, and generally there were no guidelines to be found. Also, GPs didn't treat ulcers with antibiotics or heart failure with beta blockers or ischemic heart disease with ACE inhibitors because it just didn't seem to make any sense at all.
In the early days of evidence-based medicine, there were a lot of acronyms and the lingo was still very new. In fact, when people started to refer to the EBM, I often caught myself thinking, what's this got to do with express breast milk? Over time, I began to see the importance of being able to have evidence to guide decision making. It can be a challenge, but I think providing the best care to our patients means using evidence-based medicine as much as that evidence is available.
Medical undergraduate and vocational training is increasingly problem-based. With the expanding knowledge base required to practice medicine, the ability to find, interpret and apply evidence is now a core skill.
GP registrars do arrive at my practice, expecting me to help them with evidence. When I ask them to go away and look something up, they very rarely come back to me with a textbook reference these days, and the information comes from a variety of sources. I need to be able to help them to interpret the evidence that they find.
All too true. It is important that supervisors can help their registrars practice evidence-based medicine. It will probably help your practice too. Supervisors often say that they like to teach because it helps keep them up to date. Being able to learn collaboratively with your registrar, applying evidence to clinical case discussions that you do, will help you to benefit more from having a registrar in your practice.
Evidence-based medicine is not just about reading studies. There are several components to evidence-based medicine. In this workshop, we will be focusing on just one of these, which is reading studies, a skill also called critical appraisal. But there are others. The components of evidence-based medicine are asking the answerable question, accessing the best information, appraising the information for validity and relevance, and applying the information to patient care. In summary, in evidence-based medicine, you have to clarify what it is you want to know, search well for the answers, evaluate what you uncover, and then apply it appropriately to the patient you have in front of you. Whilst this workshop focuses on appraisal, this is only one component, and it shouldn't be interpreted that the others are less important. We have some resources available to help you with the other components of evidence-based medicine.
In this workshop, we will look at appraising randomised controlled trials. There are other forms of evidence, but again, largely for reasons of time, we've chosen to look at just one. Randomised controlled trials sit high in the generally accepted hierarchy of evidence. In this diagram, you can see that they sit just below the systematic review of randomised controlled trials. You may be familiar with some examples of these, such as the Cochrane reviews. That's not to say that other types of evidence are not valuable. Some questions are not well answered by randomised controlled trials. Furthermore, a poorly designed and conducted randomised controlled trial is just poor evidence.
So, how do we tell if a randomised controlled trial is well designed and conducted? This is the skill called critical appraisal of the evidence. We have adapted a useful tool produced by Oxford University to help guide you through critical appraisal of a randomised controlled trial. We are going to briefly explain this tool, and then in the small groups we will use this tool to help us appraise an article on the use of calcium and vitamin D to prevent fractures.
In appraising a randomised controlled trial, the first step is to consider what questions did the trial ask. In doing so, we automatically bring to light the relevance of the study to the clinical problem we are considering. To do this, we break down the question asked by the study by using the mnemonic PICO, which stands for P, population, patient or problem, the group being studied; I, intervention, the treatment or action being considered; C, comparison, the alternative being compared to, and O, outcome, the outcome we are considering. For example, let's break down the questions asked by one arm of the well-reported Women's Health Initiative study into HRT. The study considered US women aged 50 to 75 who had an intact uterus, treated with specific doses of Premarin and Provera in a combined tablet on a continuous regime, and compared this to placebo. With the primary outcomes being considered the incidence of invasive breast cancer, non-fatal myocardial infarction, and death from coronary heart disease. You can see from breaking the study down in this way, it can become clearer, especially when considering the relevance of the study to your clinical question. For example, is this WHI study relevant to a slim 48-year-old perimenopausal, non-smoking woman born in Malaysia, bothered by severe hot flushes but intolerant of oral estrogen, asking whether topical estrogen therapy may relieve her distressing menopausal symptoms?
After considering the relevance of the study, the PICO, it's tempting to rush and look at the results. But if you really want to know if a study provides good evidence, you have to examine the methods. Our adapted worksheet contains some questions to help guide you through appraising the methods. Was the assignment of patients to treatments randomised? Were the intervention and control groups similar at the start of the trial? This is a check to see that the randomisation worked. The groups should be similar if it did. Other than the intervention, were the intervention and control groups treated equally? This is clearly an important question as we want to study the impact of the intervention only. Were all the patients who entered the trial accounted for? Small losses to follow-up are almost inevitable, but large losses can bias the result. Read the reasons for losses to follow-up and consider whether they are acceptable and likely to impact upon the results. Finally, were the patients analysed in the group to which they were randomised? This is called intention to treat analysis. In our example, the WHI study, if a patient stopped taking Premarin and Provera, perhaps because they had some side effects, they would still be counted as though they were in the group that was taking Premarin and Provera. So, if a patient in the intervention group who stopped taking Premarin and Provera developed breast cancer, that breast cancer would still be counted as though it had developed in a patient who was taking Premarin and Provera. Although this sounds counterintuitive, it is the correct way to analyse studies.
Next, it is important to look at the outcomes and how they were measured. Were the measures clinically relevant? For example, if you were looking at a study on gout, would you really care if an intervention raised the serum uric acid level if it did not increase the incidence of attacks of gout? Were the measures objective? If they were based on subjective assessment by either the patient or the researcher, can they be relied upon? For example, how would you measure the severity of hot flushes? How would a study try to ensure that the results were consistent between the observers?
Finally, were the researchers and the patients blinded? That is, unaware of whether they were in the intervention group or not. And if they weren't blinded, did it matter?
At last, having considered the relevance of the study using PICO, the quality of the study design, and the conduct of the study, we can look at the results.
But the results can be a bit confusing.
You must have a method to understand them.
So concentrate.
So concentrate.
So concentrate.
Let's take you through the various measures that are used in randomised controlled trials to present dichotomous answers. That is, did it happen, did it not happen type of results. We will have time to go through all of these again in the small groups.
First, there is relative risk.
Relative risk tells you how much more likely it is that an event happened to the intervention group compared to the control group.
It's a simple ratio. If both groups have the same number of events, the result is 1. That is, the intervention has not made a difference. When something is more likely in the intervention group compared to the control group, the result is more than 1. A result less than 1 occurs when something is less likely in the intervention group.
That's not a great way to present a result if you were looking to see if something is less likely. So an alternative to relative risk is relative risk reduction.
This is calculated by subtracting the relative risk from 1. It is often converted to a percentage, so the result will be X% relative risk reduction.
Relative risk reduction tells us the reduction in the rate of the outcome in the treatment group relative to that in the control group. It is important to note it is a relative measure. That is, it is always in relation to the other group in the study. There are other relative risk measures, such as hazard ratios, which, although are not technically the same as simple relative risk, for practical purposes they can be appraised in a similar way, and this actually often assists in understanding. So as this session is aimed to be introductory, we will treat them as the same in the study that we will be looking at.
But relative risk measures aren't that useful in telling you how likely something is to happen, because they don't take into account the background risk. For example, something can be 5 times more likely to happen, but still only happen rarely, because 5 times a low number is still a low number. That's why we need results to be presented as absolute risks. One such measure is absolute risk reduction.
Absolute risk reduction takes into account baseline absolute risk. How likely was something to happen anyway, and how less likely is that to happen with the intervention?
It is calculated by subtracting the absolute risk in the intervention group from the control group.
Another common way of presenting absolute risk is number needed to treat.
This is the inverse of the absolute risk ratio.
The numbers needed to treat is the number of patients we need to treat with the intervention for the same duration as was in the study in order to prevent one bad outcome.
So in summary, we have presented results as relative risks, relative risk and relative risk reduction, and absolute risks, absolute risk reduction and number needed to treat. We intend to spend some more time when we break into small groups looking at these measures.
It is also important to know whether the results are statistically significant. That is, was the study large enough and powerful enough so that we can be sure that the results aren't due to chance alone.
One common way this is done is through the use of confidence intervals. 95% confidence intervals are the range of results which would be expected in 95 out of 100 repeats of the trial. Often, relative risks are presented with confidence interval. For example, the result may say the relative risk is 0.76, with a confidence interval, usually indicated in brackets beside the result, of 0.63 to 0.89, meaning the result that occurred was 0.76, and it would be expected that were the study to be repeated 100 times, 95 of the results would be within this range.
If the 95% confidence intervals do not include a result in which there is no difference between the intervention and the control group, then the result is statistically significant.
So we've covered the basic features of appraising an article. Was it relevant? We used PICO. Was it well designed and conducted? We've evaluated the methods. What were the results? And were they statistically significant?